All right, so salam alaikum, everyone. Welcome back to Plasma Lipoproteins 2. Hope you're all well rested and well fed, and let's get to it. So we left off last time with Plasma Lipoproteins 1, talking about VLDLs and their metabolism. So let's just refresh our memories again. So we said that VLDLs come from the liver cells, and then they circulate in the blood, picking up ApoCs and ApoEs from the HDLs, and then they make their way to the endothelial cells, where they're metabolized by lipoprotein lipase, bound, of course, to ApoC2. Now, the lipoprotein lipase is able to metabolize the VLDLs and transform them into a VLDL remnant. And in the meantime, they pick up more apolipoproteins from HDL, and they give some back, of course. So there's always that trading going on with VLDLs and HDLs with apolipoproteins. Now, these VLDL remnants, half of them go back to the liver cell in order to become endocytosed. Of course, you could see here they're bound to the ApoE receptor, and then the other half go back to the liver cell also, but in order to become further metabolized by the hepatic lipase, which gives rise to LDLs. And also in the meantime, of course, it's able to donate some of those apolipoproteins back to HDL. And then the LDL makes its way into the tissue cells where it's able to become endocytosed. So let's talk a little bit about why LDLs are called the bad lipoproteins. So out of all the LDLs that we have that are made from the VLDL remnants, 80% are picked back up by the hepatocytes. 20% are the ones that go to the peripheral tissues. Now, when we talk about LDLs and all their harmful effects, atherosclerosis, all of these harmful effects come from the 20% that go to the peripheral tissues. The rest of them go back to the liver. Now, the LDLs bind to the LDL receptors by recognizing, because these LDL receptors recognize ApoB100 that's bound to LDL, but not ApoB48, because as you can remember, ApoB48 is actually attached to chylomicrons and not LDLs. So LDL metabolism. Once the LDL reaches the tissue cells, it's going to become endocytosed by the LDL receptors. Now, the LDL receptors have a clathrin coats on their surface. So the cytosolic side of the pit is coated with a protein clathrin. After binding, the LDL receptor complex is endocytosed, right? And then the vesicle containing LDL loses its clathrin. As you can see here, it loses this clathrin, and this clathrin is able to make its way back up to the surface and become recycled. And once it loses this coat of clathrin, this entire complex becomes the endosome. So the LDL then separates from its receptor, and the receptor goes back up and is able to become recycled. And then the LDL remnants are transferred to lysosomes, where they're degraded by enzymes that release cholesterol, amino acids, fatty acids, and so on and so forth. So this slide is going to finally tell us why LDLs are called the bad lipoproteins. So if you guys can remember a lecture that we had from MOL 1 called reactive oxygen species. And if you can remember, one of the many harmful effects that ROS has is actually, it has many harmful effects, but one of them is oxidizing LDL, or specifically oxidizing the ApoB that's on the LDL. Now, once this ApoB is oxidized, we have oxidized LDL, and so then we have this oxidized LDL. Now, this oxidized LDL is a major issue because here comes the macrophages. The macrophages have a receptor on them that's called the scavenger receptor class A. So the scavenger receptor class A circulates along with the macrophages, of course, circulates in the blood and looks for these oxidized LDLs. Once it finds them, it's able to mediate the endocytosis, and it's able to swallow up these LDLs. Now, the main thing we want to remember is that they're not down-regulated in response to increased intracellular cholesterol, meaning that they're going to keep on swallowing these LDLs with no inhibition whatsoever. Now, once the cholesterol esters accumulate in these macrophages, they become foam cells, and these foam cells are the ones that participate directly in the formation of atherosclerosis. Now, let's summarize what I just said again. We have macrophages that are battling always against the oxidized LDLs. The macrophages have a receptor on them called the scavenger receptor class A, and the oxidized LDLs, of course, have the oxidized version of ApoB100. Now, once the macrophages keep swallowing up these oxidized LDLs, the cholesterol esters accumulate inside of the macrophages in order to turn them into foam cells. And these foam cells, as you can see, have a direct effect on atherosclerosis. So let's talk about a little bit of HDL, which is the good lipoprotein, which is going to prevent this atherosclerosis and is going to pick the cholesterol back up from the peripheral tissues and transport it back into the liver. So it's synthesized in the liver and then released into the blood. And it uses ApoA1 for cholesterol recovery from fatty streaks in the blood vessels. So once it goes to these blood vessels, it picks up the cholesterol that's left by LDLs through the ApoA1. And of course, they carry the ApoE and ApoC2 that they donate temporarily to chylomicrons and HDLs, to VLDLs. So they transport cholesterol from the periphery to the liver, and that's what makes them the good cholesterol. So this process of reverse cholesterol transport is the basis for inverse relationship between plasma HDL concentration and atherosclerosis. So let's say we have a person with a lot of atherosclerosis, and then by some miracle, we also increase their HDL, the amount of HDL that they have in their blood. This HDL would pick up a lot of this cholesterol back up and then would decrease the atherosclerosis and would decrease its harmful effects. So exercise and estrogen both would raise HDL levels. So women, after they reach menopause and they stop producing estrogen in as much quantity, they actually become at a higher risk of atherosclerosis. So, as I mentioned before, we have the ApoA1 on the HDL that's able to bind and it's able to pick up those cholesterol that's left in the peripheries. While LCAT is the enzyme in the blood that's activated by the ApoA1. So LCAT's the enzyme that's going to help the HDL pick back up the cholesterol that's left by the LDLs. And LCAT stands for lecithin cholesterol acetyltransferase. And what LCAT does is that it esterifies the cholesterol that's already in the HDL, and therefore it buries even deeper inside of the HDL. And we want to remember specifically that it esterifies the cholesterol, because this will be very important later for when we talk about CETP. So LCAT adds the fatty acid to cholesterol, producing cholesterol esters, which dissolve in the core of HDL. So HDL cholesterol is picked back up in the periphery, can enter cells through the scavenger receptor B1. So if you can remember, scavenger receptor A is the one that's responsible for atherosclerosis. So you can remember that SRA is the bad one and SRB is the good one. Okay, so SRB is expressed at high levels in the hepatocytes and steroidogenic tissues, including ovaries, testes, and areas of the adrenal glands. So the HDL, once it picks up these esterified cholesterol through the help of LCAT, it's able to make its way to these steroidogenic tissues in order to do all its good effects. So HDL cholesterol esters picked up in the periphery can be distributed to other lipoproteins, such as IDL, thus converting them to LDL, and this is through CETP, cholesterol ester transfer protein. And what this does is that it transfers one triglyceride from the LDL in exchange for one cholesterol ester from the HDL. Inhibition of CETP increases circulating HDL levels. So you can think of CETP as the robber, you can say. So it steals these the cholesterols back from the HDL and gives them to LDL. So CETP here would be helping out LDL be in all of its bad effects. Now let's look at the way that cholesterol regulates its own metabolism. And one very, very, very important thing I want to stress about this slide is that when we talk about cholesterol regulating its own metabolism, we talk about intracellular cholesterol and not plasma cholesterol. And that's important for later when we start talking about the drugs that we give people with hyperlipoproteinemia. Okay, so when we say this, we mean cellular cholesterol. Okay, so first thing it does when we have too much cellular cholesterol is that it induces the ACAT enzyme. And ACAT, what it does is that it's able to convert the excess cholesterol into the very highly insoluble cholesterol ester that's stored in the cell. So it's able to decrease the cellular cholesterol pool in that way. Second thing that it does is that it represses the transcription of the HMG-CoA reductase gene. And if you can remember from our 9th MOL2 lecture, which is the cholesterol and steroid metabolism one, HMG-CoA is the rate limiting step in cholesterol synthesis. And the last thing that it does, and this is the most important one, is that it represses transcription of LDL receptor gene. This reduces the uptake of LDL cholesterol from the blood. So if we have repressed transcription of the LDL receptor gene, we would have less LDL that's making its way into the cell. And therefore, you would get a lower cellular cholesterol pool. But at the same time, because you're repressing the uptake of LDLs into the cell, you would actually increase plasma cholesterol. So by repressing transcription of LDL receptor gene, you would be decreasing cellular cholesterol, while at the same time increasing or causing the LDLs to accumulate outside of the cell, which would then increase the plasma cholesterol. Finally, the cholesterol regulates its gene expression by preventing nuclear translocation of SREBP2. So these are the three ways in which cholesterol regulates its own synthesis inside of the cell. So as you can notice here, we're talking about oversupply of cholesterol inside of the cell. So first thing it does is that it inhibits HMG-CoA reductase, which is the rate limiting step for biosynthesis of cholesterol. Then it decreases the synthesis of LDL receptors, and finally it induces ACAT, which would turn all of this cholesterol into cholesterol esters in order to be stored in the cell. So here we're talking about SREBP2, and the main thing we want to remember here is that SREBP2 would basically, once it's cleaved, it's able to make its way into the Golgi. It's able to make its way into the Golgi, and it's able to enhance the transcription of HMG-CoA reductase and LDL receptors. And when we see this happening when the cholesterol inside of the cell is low. So when we have low cellular cholesterol, SREBP2 containing vesicles form and move to the Golgi apparatus, where proteases would then cleave the SREBP2, and then we enhance the transcription of HMG-CoA reductase and LDL receptors. This would increase the uptake of LDLs into the cell, and this would increase biosynthesis of cholesterol. So in this way, you're increasing cellular cholesterol. So let's talk about lipoprotein A. So lipoprotein A is a variant of LDL that contains a molecule of ApoA disulfide bonded to ApoB100. So just think of it as another LDL instead, but this time instead of just having the ApoB100, it also has the ApoA that's bonded through a disulfide bond to the ApoB100. So elevated lipoprotein A concentration is an independent risk factor for atherosclerosis, and the mechanism is uncertain, but it's likely determined by genetic polymorphism. So let's get to the most important part in this lecture, which is the hyperlipidemias. So most hyperlipoproteinemias respond to dietary management. Recommendation for hypertriglyceridemic patients is reduction of caloric intake and carbohydrates, and to consume fish oil. And for hypercholesterolemia, the recommendation is less cholesterol and saturated fat and more unsaturated fat and dietary fiber. Dietary fiber is actually would inhibit the absorption of lipids in the enterocytes, which would then, of course, promote their excretion. So dietary fiber is considered beneficial because it impairs the intestinal absorption of cholesterol and bile acids. And we can also take antioxidants because, as we mentioned, the ROS, the reactive oxygen species, are in charge of oxidizing LDL, which leads directly to atherosclerosis. So if we take antioxidants, we would lessen the effects of these ROSs. In many obese patients, a balanced weight reduction diet normalizes the lipoproteins. However, dietary treatment is of limited use because of poor compliance, and that's why hyperlipidemias are treated with drugs. Now, we're going to be talking about 4 drugs in this lecture. I want you to remember that the first 3 are either directly or indirectly related to LDL receptors. So the main thing that we're going to be talking about, the main effect that these drugs will be having, 3 of them at least, is something to do with LDL receptors. And let's talk a little bit more about their mechanisms. So first, statins. Statins, as you can remember from MOL 9, they're the inhibitors of HMG-CoA reductase, which is the rate-limiting step, as I mentioned, of cholesterol biosynthesis. So they block synthesis of endogenous cholesterol, and in this way, the resulting shortage of free cholesterol in the cells induces the synthesis of LDL receptors, which increases the uptake. Okay, so we increase the synthesis of LDL receptors, and thus more LDLs are able to make their way inside of the cell, which would decrease their concentration outside of the cell. And that's the first way we would treat a hyperlipoproteinemia. And this effect, of course, is mediated largely by the transcription factor SREBP2. So when we talk about inducing the synthesis of LDL receptors, we're talking also about SREBP2 that's able to go in and it's able to increase the synthesis of LDL receptors, and it's able to activate the HMG-CoA reductase enzyme. So the second drug we have is cholestyramine. Sorry about that. Cholestyramine. So cholestyramine binds bile acids in the lumen of the small intestines and thus prevents their absorption from the ileum. So these bile acids, they're excreted instead of returning back to the liver, and in this way you would decrease their concentrations. Now, if you can remember from GI, the 7-alpha hydroxylase is the rate-limiting step in bile acid synthesis, and it's actually feedback inhibited by bile acids. So the more bile acids we have that are reabsorbed, the less the 7-alpha hydroxylase activity will be. So because we have less of these bile acids, because the majority of them are being excreted in the stool, there's less feedback inhibition, and thus the 7-alpha hydroxylase will be working more and more and more, and eventually and more cholesterol will be converted into bile acids, and then this will deplete the cellular cholesterol pool. So what do you guys think this would do? Now we have a very, very low cellular cholesterol pool. Who do we go to for help? Who do we go to in order to increase the cellular cholesterol pool? We go to LDL receptors and SREBP2. So in this way, that would lead to the upregulation of hepatic LDL receptors and reduction of LDL in the circulation. So now we have PCSK9 inhibitors. So before we talk about the inhibition part of them, let's talk about PCSK9, normally what these PCSK9s do. So PCSK9, what they do basically is that they bind to the LDL receptors and they prevent them from being recycled. So they would increase the cholesterol in the bloodstream because you would have less LDL receptors and thus less uptake of LDLs into the cell. And so the PCSK9 is predominantly produced in the liver. And so when we have PCSK9 inhibitors, we're able to allow for LDL receptor recycling, and thus we're able to increase the uptake of LDLs into the cell. So I added this slide of my own because I noticed that there was a lot of confusion between the differences between PCSK9 and regulation of cholesterol biosynthesis. So what I want to mention is that PCSK9 inhibits LDL receptor cycling, causing LDL to accumulate outside of the cell and causing increasing plasma cholesterol content. Now, high cellular cholesterol inhibits synthesis of LDL receptors, causing cholesterol to increase in the plasma, but subsequently decrease inside of the cell. So basically, when we talk about the cholesterol, it's able to regulate its own biosynthesis. It's able to do that by decreasing the synthesis of LDL receptors. Now, as I mentioned, this decreased LDL receptor synthesis would cause accumulation of the LDLs outside of the cell, but because you have less uptake, you're also decreasing the cholesterol inside of the cell. At the same time, you have PCSK9 that's able to inhibit the LDL receptor recycling, and again, because you have low LDL receptor activity, these LDLs will accumulate outside of the cell, and they're going to increase plasma cholesterol content. So the PCSK9 inhibitors is given to treat hyperlipoproteinemia because the PCSK9 normally what it does is that it would inhibit the recycling of LDL receptors. So, and the final drug that we're going to be talking about is the nicotinic acid treatments. So it comes from the cofactor niacin from vitamin B3, and it reduces VLDL production and increases HDL cholesterol. So through reduced CETP-mediated lipid exchange between HDL and VLDL, allowing HDL to remain in the circulation longer. So as I mentioned, CETP steals the cholesterol from the HDL and gives it back to VLDLs. And thus it would decrease HDL concentration and increase VLDL concentration. So nicotinic acid, what it does is that it reduces the VLDL production by reducing the effects of CETP. Thus, you would increase HDL and decreases VLDL. So let's talk about the different types of hyperlipoproteinemias. So type 1 is called hyperchylomicronemia. So just from its name, you could probably guess what the major lipoprotein associated with this condition is. And of course, it's chylomicrons, which contain the most triglycerides, as I mentioned. So it's a rare genetic condition, and it's caused by inherited deficiencies of lipoprotein lipase or ApoC2. Now, if you can remember, lipoprotein lipase, it's able to recognize the ApoC2 on the surface of chylomicrons, and that's what's able to activate its the chylomicrons metabolism. So patients have eruptive cutaneous xanthomas, abdominal pain after fatty meals, and recurrent attacks of pancreatitis, but no excessive atherosclerosis because as you can see here, we have reduced LDLs. So LDLs reduced to 20% of normal or less, okay? But you do have abdominal pain after fatty meals and cutaneous xanthomas. This is the main thing that you should be looking at when you're solving questions about the hyperchylomicronemia. So the second type is hyperlipoproteinemia type 2, and it's caused by extremely elevated levels of LDL cholesterol. And this has to do with genetic mutations in the LDL receptors, apolipoprotein B100 or PCSK9. So if you have genetic mutation in the LDL receptors, again, you would have accumulation of the LDLs outside of the cells. Now, as I mentioned, LDLs recognize the ApoB100 on the surface of these LDLs, and that's what's able to induce its endocytosis. So if you have a genetic mutation in either LDL receptors or apolipoprotein B100, you're going to increase the levels of LDLs outside of the cell, and those are going to accumulate, and they're going to cause type 2 hyperlipoproteinemia. And PCSK9. So PCSK9, again, would inhibit the recycling of LDL receptors, which would do the same thing as the genetic mutations in the LDL receptors. They would cause accumulation of LDLs outside of the cell. So without treatment, you would have atherosclerosis because of the increased, the accumulation of LDLs outside of the cells, as well as xanthomas. So they contain cholesterol-laden foam cells. And finally, we have type 4 hyperlipoproteinemia or hypertriglyceridemia. So it's polygenic, and it has to do with elevated VLDLs, and where you have triglyceride is elevated to a greater extent than cholesterol. Now, if you could remember, I mentioned that chylomicrons have the highest percentage of triglycerides, but VLDLs, when you have hypertriglyceridemia, these usually would be caused by increased VLDLs. And as I mentioned in plasma lipoproteins 1, this is because chylomicrons are a source of exogenous sources of lipids, so they're diets, and VLDLs are more endogenously synthesized lipoprotein. So you would have an increased risk of atherosclerosis because the more VLDLs you have, that are turning into LDLs. So let's get to questions. Question number 1. A defect in which of the following proteins or complexes would result in the inability of HDL to transfer peripheral tissue cholesterol to circulating LDL? What do you guys think? So the answer is C, LCAT. Now you might be thinking, well, the enzyme that's responsible of transferring cholesterol from HDL to LDL is actually CEPT, or sorry, CETP. So how come here the answer is LCAT? Well, this is because LCAT, as I mentioned, it's able to estrify the cholesterol. And CETP, what it does is that it transfers the esterified cholesterol from HDL to LDL. So if you have an inability to even esterify the cholesterol to give to HDL, you're unable to then hand off the cholesterol esters from the HDL to LDL. Question number 2. The hypercholesterolemia that is associated with familial hypercholesterolemia is due to which of the following? So we're talking about type 2 hypercholesterolemia. So of course, the answer would be D, defective LDL receptors leading to reduced uptake of plasma LDL and IDL. And this would, of course, increase, or this would cause accumulation of LDL outside of the cell. Now, some might say that you could also consider A, abnormally elevated production of LDL, to be true. And while that would also cause accumulation of LDLs outside of the cells, it's not actually associated with type 2 hypercholesterolemia. When we talk about type 2 hypercholesterolemia, we're talking about something that has to do with the LDL receptors. So either LDL receptors, ApoB100, which is able to bind to the LDL receptors, or PCSK9, which would inhibit the recycling of the LDL receptors. And finally, a 13-year-old girl presents with extensive eruptive xanthomas and hepatosplenomegaly. She does not have type 1 or type 2 diabetes, as an analysis of circulating insulin and glucose levels indicates that they are normal. Examinations of plasma indicates that it is quite milky. So our first keyword, indicating lipemia. Analysis of the lipid content of the plasma shows a massive accumulation of chylomicrons and triglycerides. The teenager is placed on a fat-free diet, which reduces the lipemia and all of the other clinical manifestations. A deficiency in which of the following apolipoproteins would account for the observed symptoms of this particular hyperlipoproteinemia? And the answer to this would, of course, be D, ApoC2, because the ApoC2 is able to be recognized by the lipoprotein lipase, which is in charge of metabolizing the chylomicrons. Now, the reason I added this question, although I added a very, very similar question to my last PAL session, which was plasma lipoproteins 1, I added this in order to show you that although this might seem like a scary question, it's a very long clinical case. All you need is maybe a couple keywords that it is quite milky, that the plasma is quite milky, and that it shows a massive accumulation of chylomicrons and triglycerides. So these types of questions, although many people like to skip to the last sentence and read the last sentence only and then answer the question, I prefer to just very quickly skim the question and circle a couple keywords that I find, and that way you're able to solve this question very, very quickly. So that's all for the plasma lipoprotein PAL sessions. Thank you very much, and good luck to you guys, and also good luck to me. Thank you so much.